Hello and welcome. I am Connie Ray, and I am the moderator for this episode of Talk It Out Tuesday, Developing Nevada's Crisis Care Response System. And in this episode of Talk It Out Tuesday, we're going to talk about the statewide planning and development of Nevada's Crisis Care Response System. Unfortunately, people in Nevada experiencing a behavioral health crisis are not routinely being served in a timely, trauma-informed manner. Inability to access appropriate and timely care can be a very serious consequence. It results in unnecessary decompensation, frequent utilization of jails, emergency departments, increased trauma, stigma, and a decline in their overall well-being. Now, currently, law enforcement is often inappropriately used as the primary responder to mental health crisis calls. And while law enforcement has a role in crisis response, their charge of public safety means they should not be the primary resource for assisting and responding to individuals who are in the midst of a mental health crisis. An additional component of Nevada that we have that creates a very unique challenge for a coordinated crisis care response is the rural nature of our state. The majority of our state is a rural population. Now, this presents specific challenges due to lack of access and timeliness of crisis response services, a lack of infrastructures and facilities, as well as barriers to transportation, to access services and facilities that can even provide the appropriate level of care that's needed. Knowing all of this throughout the statewide planning, Nevada is moving towards building a crisis care response system that is both supportive of local communities, families, and individuals by fostering resilience and is responsive to the needs of individuals in crisis. To talk to us about the current planning of a statewide crisis care response system, we have with us today Kelly Marshall, principal of Social Entrepreneurs, Inc., and the facilitator of the statewide planning of Nevada's crisis care response system. Also with us is Jessica Flood. She is the coordinator of the Northern Nevada Regional Behavioral Health Board. And as always, with Crisis Support Services of Nevada, the executive director, Rochelle Pellisier. It is so wonderful to have you all with us today. Thank you so much. We're excited to talk about this and jump right into this journey on Talk It Out Tuesday. And Kelly, I'd like to start with you. Why do we need a statewide crisis response system?
Well, Connie, if you think about an emergency, let's say you crash your car, right? Someone immediately calls 911, and within minutes, fire, police, emergency responders show up. They make sure if you're hurt that you get the care you need, and it happens very quickly while they're directing traffic and making sure that everyone around them is safe. In a behavioral health crisis, that's not the case. And that's what we want to build. We want a system that allows for people, if they're having a bad day or they're having a mental health crisis, to have someone to talk to right away. And if that person who is talking to them determines, boy, they could really use an assessment, we're not sure exactly what they need, then the next piece would be to have someone who could go to them like a first responder and be able to assess them and get a sense of what their level of need is. And if they needed to go, for example, to a crisis stabilization facility, that one, there would be a facility available, and two, that transportation would be available, that they could just put them in their car, get them to the right place. What this does is it provides an ease of access to services, it reduces trauma, it destigmatizes mental health as an issue, which is important throughout the community. And it ensures that there's a continuum of care so that if all that person needs is to talk to somebody on the other line, they get that right away. If they need more in-depth conversation and an assessment, they get that. And if they need to go to a safe place and be surrounded by people who have experienced what they've experienced and can help them problem solve to resolve those issues, that they have that as well. And in Nevada, we have some of those pieces, but we don't have them as built out as we need, and they aren't all currently connected.
right now we get those crisis calls for people who have figured out how to get a hold of us. Unfortunately, we have been deemed the best kept secret in the state, and that's not a good thing for crisis intervention. So this crisis intervention planning gets us working together to help our citizens instead of working in our own little silos. That is what is so important about creating the system across the state.
Jessica, why is it especially important for those Nevada rural communities and the frontier communities? Why is this setup so vital to them?
Nevada already has limited resources, and in the rurals, that's really extreme. There's a real lack of resources, and so people who are living out there have a hard time accessing mental health treatment when they need it. And sometimes that leads them to waiting until they get to a point of crisis. So when they're in those crises, that's when they're really accessing these limited hospitals with 2 ER beds. They're working with EMS and fire crews that are volunteer. And then they're utilizing law enforcement who are covering huge stretches of territory trying to keep the community safe. So it really strains those systems. The other piece of it is that it's pretty traumatizing. Needing to use law enforcement to transport people in mental health crisis into the urban areas, they have to be handcuffed in the back of a car. And there's nothing that's more stigmatizing than something like that. When you're having your worst day and you're getting handcuffed even though you haven't committed any crime. The really exciting thing about this initiative is that it has taken the rurals and the urban areas into account and really looking at the different pieces that are accounting in all of those areas. They're using us, these regional behavioral health coordinators, to really reach down into the communities and see the specific needs of each community and really bring that up to the state level. So I think this is a unique initiative in that way, that we're trying to regionalize and use that community input. And I believe that this is how the state's planning to move forward, is to start regionalizing mental health.
There is some, but we're not utilizing the services we have effectively because we're not coordinating them across the state. So this coordinated service provision across the state really helps us to use the limited services we have already much more effectively also. So that's what's really one of the really important things for the rural counties, and quite frankly for the urban counties too, to really utilize the current services that we have more effectively.
That's a really great approach. And that was the exciting part about this is, you think, how do you lift up this big system? And really, we looked around and said, wow, we've got a lot of the pieces here. And like Rochelle said, how do we just start really coordinating them so we're using them in an effective manner?
You mentioned about putting someone in handcuffs. Our last episode of Talk It Out Tuesday, we spoke with Nevada Attorney Ford, and he was talking about that specific thing, that it's a position that they get put into and they know that doing what they're doing is not a benefit to that individual. So that is why even police force is looking at having a better partnership with your services, because they feel that's not their job and it's not going to be in the betterment of that individual who's going through that crisis. And Kelly, back to you. We know that the human cost of limited crisis care response services, it's expensive. Is there a substantial cost of continuing to treat people experiencing a crisis through Nevada's emergency departments and then the limited acute inpatient care?
What we know is that on average, about 70,000 people, slightly more than that, throughout Nevada, so these are our family members, our friends, our neighbors, are going to experience a mental health crisis in the course of a year. And so what that often looks like is that a first responder will respond. It could be the police, it could be an ambulance. They may end up being placed in an acute inpatient bed. First, they may have to get medically cleared and go to the emergency department and wait hours, sometimes days, to get cleared based on the other emergencies occurring. And so the total cost of that, using a nationally accepted calculator, which is called the Crisis Now System Calculator, estimated that for those people in Nevada, in the course of a year, the cost would be just short of $350 million, right? When we add in emergency responders, the acute inpatient beds, potentially being in jail for a period of time or being handcuffed and in the back of a car to be transported, and then waiting in an emergency department, plus the emergency department costs. And that's before they've even gotten any help, right? What we know is that if we implement fully a crisis care response system, that number is cut by 43%. The savings would be almost $150 million. And so when we look at Jessica's point, which is that people are being traumatized with the existing system, you would be reducing the amount of trauma and you would be increasing efficiency. They'd be getting the care they need sooner, and we would not be stressing all of the other parts of the system. And we could take those savings and invest them into a crisis care response system.
That brings us to a point where I really like to talk about Maricopa County. They were one of the first ones who implemented, they called it Crisis Now, but a crisis care response system. And within 1 year of coordinating their systems, having people in a mental health crisis taken to a facility that provides the mental health care that they need instead of going to a jail or an emergency room where the police has to stay with the person in the crisis in the emergency room for sometimes hours on end rather than be out and doing their jobs. In 1 year in Maricopa County, they saved enough money to, in law enforcement, not having them have to wait in emergency rooms, they saved the equivalent funds to 37 full-time equivalent police officers in 1 year. And then in the hospital system, because they weren't taking everyone in a mental health crisis to an emergency room, they saved also $37 million that they were able to reinvest in the appropriate services for people in a mental health crisis. So that shows you right in dollars and cents how vital these systems are, these coordinated systems are.
Kelly, can you tell us a little bit about the series of statewide planning webinars that were held during June and July? Because I think it kind of goes into detail about bringing something like this to Nevada.
Yeah, so Nevada is definitely interested in continuing to build on the system that we have. Initially, we had planned to send teams to places like Maricopa County so that they could see the system and get a better feeling for it. And that would have included policymakers, law enforcement, first responders, behavioral health providers, elected officials. With COVID, we were not able to do that. And so instead we pivoted and we said, we'll bring them to us. And so over a course of 6 weeks, every week for an hour and a half, we convened over 100 stakeholders all across the state, including representatives from each of the 5 regions. And we started with, where are we today? What does Nevada have? What are the national guidelines? There were just national guidelines published in April of 2020 that outlined, here are the minimum standards that we should have, here are the best practices. So we wanted to educate everyone that was participating on the vocabulary and the parts of the system that Nevada needs for a full continuum of care. And so we started with that, where are we in Nevada? And then we went into a series that included talking about the funding, how different states have funded a crisis care response system, how they braid funding, how they can use Medicaid. We then went into each of the components of a crisis care response system. And there are 4 components. So we covered each of them in detail. We had stakeholders from Colorado, from Georgia, and from Arizona who were able to share not just how they built their system, but what their lessons learned were, what they would have done differently so that Nevada can leverage that. And so we covered the crisis center, the crisis call center hub, which clearly that is the piece in Nevada that is most built out. Then we talked about mobile crisis teams. And we have mobile crisis teams of various descriptions or assortment of personnel throughout the state. But we don't have full coverage across the state. So we learned about that. And at the same time, we're learning not just what are other states doing, but what are the national guidelines? What should Nevada build so that we build smart and we build efficiently? And then we talked about crisis stabilization facilities, and that's having like a living room like setting where people can go. They don't actually even include beds in part of the facility. They have recliners, they have piers. It's supposed to be a warm home-like setting that people can de-escalate in and talk about what their problems are. And then finally, baked into all of this are these essential principles and practices. And that includes a focus on safety, a focus on trauma-informed care, ensuring that there is zero suicide. And so people were able to listen to experts from other states, but we also had folks who were peers or who had lived experience. And they shared, for example, their experience going to an institution because there wasn't a crisis stabilization facility. Or they talked about being handcuffed and being put in the back of a car because there wasn't an adequate mobile crisis response that didn't focus on law enforcement. And they also talked about, we had one of our great lived experience folks talked about a trauma she had experienced 30 years ago that was significantly impacting her ability to function, and that she picked up the phone and she was so fearful that someone was going to say to her, this happened 30 years ago, like why haven't you gotten over it? And instead the person answered the phone and said, how can I help you? And she explained, and she said, let me share some resources with you. And that made a significant difference in that woman's life. And so we heard from our neighbors, we heard from other states, and then we used the national guidelines to really educate all of our participants so that we would all have a shared vocabulary and understanding as we build the system together.
For the first 6 sessions in this series, we had someone speak and share their experience, as Kelly talked about, both from calling our call center and how that changed their life, to different episodes in their lives of needing to be either hospitalized or in a place where they were unsafe and really needed assistance. That person talked about being handcuffed by police. Now, if you're not in enough crisis, let me tell you what, have the police arrive, and the only way you can get help is to be handcuffed and put in the back of their vehicle. That's some serious crisis right there. So we really wanted to look at and share those shared experiences so that everyone planning our system across the state really intimately understands the issues or the problems of not having this kind of coordinated care. So it was very informative. It helped us all to kind of walk in the shoes of people who are experiencing mental health issues across the state, live with the stigma of having, the police show up at your door with lights blaring just because you're having a mental health issue. All your neighbors now know about it. Everyone knows about it. And what that does to your mental health when this kind of thing happens to you. So it was just a really well done, help the people who were involved in this planning understand our services currently and where we want to go, so that they can help us make an educated choice as we grow our system.
I think it's wonderful that you're actually getting response from individuals that have been in that crisis and have experienced that, because I think it educates you on how to put those core elements together better for those individuals. You mentioned these core elements, Kelly, but do we have the elements that we need for crisis response system here in Nevada? What do we need?
So I'll talk a little bit about what the ideal is. So it starts obviously with the crisis call center. And so that would be staffed 24/7 using technology. There would be a real-time coordination across the system. What that would mean is you would have telephone, you would have text, you would have chat, you'd have an array of platforms for a region, and you would also have clinically trained staff. And that staff would be equipped to handle a variety of mental health or substance abuse concerns and triage them to the appropriate services or to provide support as needed. That crisis call hub can also collect big data so that we can understand who is in crisis, where are they in crisis, and how are those crises resolved, and at what cost. So that's the first piece. The second piece is a mobile crisis team. And the mobile crisis team offers community-based outreach, intervention, and support to any individual wherever they're located in a timely fashion. And the goal is to get the best outcome for that individual. And the teams should have a peer support in conjunction with a professional mental health clinician or a paraprofessional. Programs usually include some kind of contractual ability to do transportation, to provide medical backup, and to respond within a period of time so that somebody isn't sitting in crisis waiting. So that would be the second component. The third thing is for those folks that cannot be helped simply by calling or simply by connecting with that mobile team, that they would be able to have a facility that they could go to for what's called short-term subacute crisis stabilization. So that provides support and observation. It's at a much lower cost. It doesn't have the overhead associated with a hospital acute care bed. And the crisis stabilization are delivered in home-like settings. They're more comfortable than a typical hospital setting. You don't put on one of those paper robes. You get to keep your own clothes on. And they cannot turn away someone who has a mental health crisis. They have to be prepared to accept everyone, so zero refusal. That allows law enforcement the confidence to say, I can respond to this call if for some reason I got the call instead of the mobile team, and immediately drop them off and be in and out in 2 minutes, knowing they've done their job and they can go back to ensuring public health and safety. So the crisis stabilization program's role is to provide assessment and triage for each individual so that they receive the care that's appropriate for them. And then the final piece is the essential principles and practices. And that's what we talked about needing to be baked into each of those other three components. So that would have a recovery orientation. It would include trauma-informed care. There would be a significant use of peers as staff, and then a commitment to zero suicide or suicide-safer care, as well as strong commitments to safety for both the consumers and the staff, and strong collaboration with law enforcement as well.
How do the assets and the gaps differ in the rural and frontier counties as opposed to Clark and Washoe County?
Two of the elements of the Crisis Now model, the crisis call line and the mobile crisis response teams, can actually look pretty standard across the state. Obviously, we have the Crisis Support Services of Nevada, and it's statewide, so that is something that can easily just be applied. And same thing with those mobile teams. You know, you kind of set up a program. The one thing that I think we're going to see in a difference, that the challenge will be, is the response time in the mobile teams, how to respond to a large region. Transportation is one of the largest issues in the rural counties. So, you know, really trying to address and make sure that these mobile teams can transport people when they need it. And then the real challenge will be trying to figure out how to create scaled down crisis stabilization centers in the rural facility or in the rural counties. So there's less resources, less providers, and there's a smaller population base. So you can't have this big scaled up facility. So how do we have little satellites where people can come and access maybe some peer support, get some food if needed, and then be able to sit in, a chair and relax for a little while to see if they really need to go on to a larger hub. So Colorado has done a really good job with that model, and we're definitely looking at we're looking at lessons learned from them so that we can apply them here to develop that system.
We're talking about innovation here, which is really vital when we're talking about those rural and frontier counties. As we've talked to other states and other providers of these kinds of crisis systems, what we've talked about is being able to, in real time, get help to someone that isn't law enforcement, that is a peer or a clinician, get that help to someone in person. Well, when you've got the frontiers and the rurals, that can take someone 7 to 8 hours to get out to someone in crisis in the frontier. And that makes a system really hard. But we can look at innovation. Right now, we have a rural care team that does immediate crisis intervention through a licensed clinician, but it's done like telehealth. It's done on a computer, iPhone, or a smartphone, providing those types of services and looking at that innovation. So how do we use that innovation and get people the services we need? Sometimes in the frontiers, they don't have adequate internet or they don't have a way to do telehealth. So how do we work together as a state to get the best services we can in any way that we can do that and make sure we're coordinating it?
I've talked with a lot of hospitals that have said that telehealth was already being implemented prior to COVID, and it has really been a life-saving tool, and that they really had expected that to grow in the rurals. And kind of going back to what you talked about, Jessica, if you were to have almost like a satellite location where you could have good internet, that person then in crisis could come and have some sort of telehealth care, which I think is a brilliant idea. Going back to what Rochelle was saying, innovation, if anything, the joys that we see at the end of all of this craziness is that we are going to be able to provide better health care, including mental health care, to those in need. And I want to kind of go back to the planning sessions that you had. What are some of those statewide priorities in regards to both rural counties and the larger populations of Nevada?
Well, Connie, one of the things that was really exciting is after we did the 6 series to educate everyone and get them on the same page about the crisis care response system, we then did a half-day statewide summit. And that included all of the participants who had come week after week to learn. And we asked them to look at regional assets and gaps that each of the regional behavioral health coordinators had worked with their stakeholders in their regions to identify. So this is using a nationally based and accepted tool called the Crisis Now tool. And they, in essence, went through and assessed what are the gaps and what are the assets related to a crisis call center, related to the mobile teams, related to crisis stabilization facilities, and related to the 4 essential principles. And we were able to do breakouts with each of the regions so that they could set their own priorities and identify what they felt like the place they wanted to start. And so the picture statewide is that we know that we don't have sufficient crisis stabilization facilities in either rural Nevada or in our urban areas. We also need more mobile teams, and we need mobile teams with peers and with clinicians. So those were the top 2 priorities. But then we bucketed things around 5 key areas. So one of them had to do with political and community will. And I can't underscore enough how important partnerships and non-traditional partners, so that we're not just looking at the state or we're looking at the county, but we're looking at all of the different stakeholders in a community to build that political and community will for a crisis care response system. And the 2 priorities for them were to promote behavioral care, behavioral health care, in the same way that COVID is being treated, as a public health crisis. And even one of our speakers in our first session said, what if we treated mental health crises with the same attention that we're treating COVID? And so that was one of the wishes. The other was to create regional behavioral health associations or authorities that can help plan, evaluate, fund, and be accountable for the system in their region. We're also interested in quality care. And so some of the priorities included that zero refusal policy so that somebody could be served and there would be, no turning law enforcement away. But then to do that, we also need memorandums of understanding or MOUs with crisis care response system partners. So that's the crisis call center and the mobile teams and the facilities so that we can have warm handoffs and transition people into care really efficiently with the least amount of trauma. The third area were quality outcomes. And that's to ensure that there's this continuous quality refinement, that we collect the data that would come from the crisis call services of Nevada as that hub, and that we use that data to tinker with or tweak the system as needed to respond to Nevada's specific needs. And the other piece about that is having folks who are serving or providing services put their data into one system so that we can collect across the continuum data on what is the experience of somebody from the time of a call to the time that they are released from care. And so that system is called Open Beds, and that's already under development and has just gone live. So we're really excited about that. Funding was a major concern for all of the stakeholders. That was the #1 priority. And what they really want is for Nevada and all of the stakeholders to look at how we can braid federal, county, state, private, and Medicaid funds to fund the crisis care response system and ensure that there's sufficient funding for sustainability and for growth so that we don't build something and then have it go away. And then finally, there was a focus on data, ensuring that we identify what is the really important data to collect. Is it the amount of time it takes to get a mobile team to somebody in crisis? Is it how long it takes for somebody to pick up the phone to respond to a call? Is it the transportation time? And is it the outcome? How long did that person stay in that recliner before they were discharged? So that we can tell the story of the reduction in use of emergency rooms and acute facility, hospital bed facilities. The average stay in an acute facility is 6 days. In a crisis stabilization facility, it might be 23 hours. And so there's just a tremendous cost savings, but there's also the true opportunity for a person to say, okay, I've received the help that I need. Now I can go back to my life without having been hospitalized for 5 days. And so collecting that information as well as information on how much are we diverting from jails? How much are we diverting from emergency departments? So those were really the priorities. And it's a big lift, but there is a lot of energy and engagement and passion around the crisis care response system in Nevada.
This system and the Open Beds database and referral system that just went live will also allow us to see what we have in place that is working with data to back that up, and what we don't have in place that we need to fund or figure out how to prioritize because we're not serving people at the right time in the right place. And we'll have good, solid data to back that up. We all in the past just said, well, we know we don't have enough services. We've all heard this. We don't have enough services. But we haven't been able to back those statements up with good data. And we all know that legislators and everyone else to be able to fund things appropriately need really good data that we can show, and really good stories, sort of like our lived experiences that we talked about at our seminars. Really good lived experience and stories about that to share with our legislators and with the leaders of our state as we plan out and grow these services.
What is the call to action? What is the next steps for Nevada, both regionally and at a state level?
We now have to take what we've learned and push it out to our communities. So the first thing is to really foster political will, and that's going to really rely on the regional behavioral health coordinators working with their policy boards so that they can set regional priorities that support building this system statewide. So that's really step one. But we also want to lift up and support leaders in communities. We have many people who have been engaged through this process. We don't want to lose them. So we want to continue to engage them and have them be part of the solution. There are others who still don't know enough, right? And so we need to take what we've learned and educate key stakeholders on the role and the significance of a crisis response system. And then we need to promote and advocate for policies that will improve the crisis care response system. And as we do that, evaluate the programming that is already in place to ensure quality and consistency. So at the end of the day, we want to be accountable. We want to be good stewards of all of the resources, but we need to engage the community. And so those regional behavioral health coordinators and their policy boards are going to play a critical role because they are the direct connect to the community members in their region.
Thank you to all three of you for your continued dedication to help those in mental health and crisis situations. I think during COVID-19, we have ripped the Band-Aid off, and at this moment now, we know more so than ever that we need to be there for those in crisis. And I would encourage you, if you would like to learn more about the crisis care response system and the virtual immersion and the national guidelines, pre-read the materials. You can watch videos of each immersion session and the virtual summit by visiting socialent.com. That's socialent.com. I highly encourage you to check those out. And of course, going back to people in crisis support services of Nevada is there for you 24/7. You can contact them at 1-800-273-8255. You can also text CARE to 839-863. You can also visit their website. You can visit them at cssnv.org. And please do keep in mind that Crisis Support Services of Nevada, they are a charitable organization. They are helping all Nevadans, people across our country. So please consider making a donation to this fabulous organization. We want to keep up with these Talk It Out Tuesday episodes, and you're a part of making that happen. Again, you can make that donation at cssnv.org. And thank you so very much to Kelly Marshall and Jessica Flood for joining us to talk about this very, very important topic. And again, you can join us. We'll be back on Tuesday, September 22nd. Thank you again to Rochelle Pellissier, the Executive Director. She is always working so hard to make sure we have these wonderful episodes of Talk It Out Tuesday, and we look forward to our next one again happening September 22nd. So thank you all so very much for all that you do.